Okay, so now we'll get on to our last session, and I'll invite Dr. Sloane Guy, who's going to lead the discussion, to invite the panelists. But before I do that, I'd just like to point out, for those who are unfamiliar with the phrase, Houston, we have a problem, it's a reference to a remark that was made by the astronauts on Apollo 13 when their navigation system broke down, and I think it justly qualifies for as a serious contender for the understatement of the century.
So I'd like to invite our panel up. A couple of them are already up there. We would like to invite Sam Balke, as well as Stephen Hoff, Elizabeth Herrera, you there? Okay, and Nirav Patel. So the discussion is on minimally invasive mitral and robotic mitral. I suspect the reason that I was put at the end of the day was to kind of liven things up on a very important topic. And I think what we'd like to start out with is this slide. I've shown this slide before, but basically there's a tsunami of catheter-based interventions coming our way. I don't know, how many of you were at the ACC last week? Yeah, so I was on the floor when they presented the two low-risk TAVR papers, and I can tell you that's a seminal event in the history of cardiac surgery, for better or for worse. You know, things are changing, guys, and if we don't change with them, we're going to be extinct real soon. So I want to just show a couple of provocative slides, and then we're going to go over a case. So my answer to this is I'm not giving up without a fight. I came here to be a surgeon. I want to do surgery. There's going to be some catheter components to it, but I'll be darned if I'm going to just lay over and let cardiologists take over completely the practice of mitral valve procedures. And so for me, that was robotics. For others, it may be different. So let's start with a clinical scenario. It's 2019, okay? And I want to know the panelist opinion and then maybe some of your opinions. You have a 57-year-old male, symptomatic, severe MR. He has a left ventricular insystolic diameter greater than 40, so he's got class 1 indications for mitral valve repair. He has a Barlow's valve, so maybe a little more complex than the standard P2 prolapse. EF's a little bit down, normal coronaries, normal CT angiogram. My first question for the panelist is, what's the right procedure and who should do it? Why don't we start with Sam?
Thanks, Sloane.
You think I should do it? I agree.
I think I should do it, first of all. The guy lives in Chicago, or maybe even lives in New York. I should still do it.
Yeah.
So he's 57, he's young, he's healthy, he's got severe MR Barlow's valve. I feel comfortable fixing that robotically, totally endoscopic the way I do it. His CTA aorta ephemerals are normal, so I would use the endo balloon, and then I would do a bileaflet repair, most likely cords and a ring.
Okay, how about you, Steve?
I can't argue with that, except to say I think most of the surgeons in the room ought to be able to take care of that, and I think it's your repair technique of choice. So if it's direct right thoracotomy, direct access, robotic access, or transsternal, you go with what you do best.
Okay, Nirav and Elizabeth?
So I would do it minimally invasive, robotic, or right chest approach repair with a full ring. He's 57. We don't know what's going to happen in future, so you should also keep an option open for valve in ring in 20 years. So with a full ring and robotic or minimally invasive approach, whatever.
Okay, let's take a poll of the audience. How many people in the audience would do a full sternotomy? And don't be ashamed to raise your hand. That's still the most common way this would be done in the United States. Okay, we have one. Anyone else? Sternotomy? A couple more? Okay. How about a quote-unquote mini thoracotomy? Okay. How about mini thoracotomy with a robotic system? Okay. How about totally endoscopic robotic? Okay. How about upper mini sternotomy through the dome? How about lower mini sternotomy through Waterson's groove? Anyone? How about a MitraClip? How about transapical off-pump neocords with or without a percutaneous annuloplasty ring? Anyone? Any takers?
No.
Well, there's no doubt that you could fix a Barlow's valve with neocords transapically and a ring. You probably could do that. Whether that's the right thing to do or not, I don't know. I think the follow-on question is, one thing that has always bothered me is that all of us, myself included, we tend to recommend to patients what we do. A, what we're capable of doing, and B, what we believe in doing. Because any good cardiac surgeon worth their salt is going to be passionate about the way they do it, right? Is that a problem? If there's advantages to, say, minimally invasive mitral valve surgery, should we not be sending these patients to someone else? Sam?
That's a tough one. I think the question is, what you're really asking is, should there be subspecialization in cardiac surgery? And
Yeah.
I mean, the same would apply to coronary disease. If you have a young patient who has 3-vessel coronary disease, should you slap a lima and 3 veins through a sternotomy, or should you send that patient to somebody who can do all arterial grafting off pump? And what do you just put
Mike
up
Mack wrote that editorial in JTCVS last month, calling for coronary expertise.
So I think that the answer is, yeah, we all do what we know how to do, and we recommend what we know how to do, but there's always going to be somebody that can do it differently, and perhaps, one day the literature will show that that technique is better, but until it is definitive that one technique is significantly or demonstrably better than another, it's hard to justify, sending a patient. Today, there are certain scenarios where I do send a patient elsewhere. If I have a young patient with a bicuspid aortic valve with severe AI, I don't operate on that patient. I send that patient to somebody who can do an aortic valve repair, or at least has experience with that operation. I think it's an ongoing conversation.
Elizabeth, what do you think about this topic of...
Okay, so I have to preface that I am a cardiac anesthesiologist. I've been practicing for a long time. I've seen mitral valves repaired, probably more mitral valves repaired here in Houston than I have seen absolutely anywhere. But I think what we have to keep in mind is this guy is 57. This guy's my age. And I feel that if it were me as a patient, I feel like maybe I have like another 10 some years working. I want to make sure that I have the best repair that will be long lasting, that no matter, I don't care if you do I happen to live in Houston. I know, where I go and, what I would like to have done. But if it's a matter of lasting forever, or I have to go back to the operating room, I would take whatever procedure would make me have the longest lasting repair.
So along those lines, Joanna Chikwi wrote this very nice paper, and there have been others, basically correlating mitral valve repair to volume rate, not necessarily how it's approached, whether it be minimally invasive, sternotomy, what have you, but probably the most evidence that's out there in favor of who should do it revolves around surgical volume rather than what particular technique they do it. The median number in the United States is about 5 per surgeon, mitral valve procedures. In the state of New York, in this paper, it was 10 per year, and there was a big difference. The repair rates were higher in high volume surgeons' hands. The survival was actually better. Reoperation was less. On the other hand, if you look at this, it's sort of like a scattergram. There were low-volume surgeons that performed quite well. And so can you really say that surgeon that did 5 last year shouldn't do it if all 5 of them went perfectly well? I mean, this is a difficult question. Of course, it's in the context of, let's face it, an extremely competitive profession where everyone's scrapping for cases, and so they're going to recommend what they know best. I'll turn the microphone over in just a second, but I had a really cool lifetime experience where I spent 2 years as a general practitioner in the Army. And I used to read Reader's Digest every month. Reader's Digest has a great health section if you want to know what's going on in healthcare for the real people, outside of our microcosm. And there was a great article a few months ago where it said that that doctors have a problem and that they only recommend what they're capable of doing for selfish reasons. I think that's a tough thing because I think we've all, we're passionate about what we do, but there are some ethical concerns. But there is an argument out there that mitral valve surgery itself should be a subspecialty. independent of how you do it. What do folks think about that concept?
So I think it has to, if you have to have a good repair rate, you have to do more, and I agree. But this graph shows that if you have adequate training, you don't need to do 250. I think there's some threshold volume. I don't know what it is, but I think you have to be adequately trained. Probably take a year out after fellowship to get trained, to train in a specialist in mitral valve, especially if you want to do minimally invasive. On the other hand, also, we all talk about that we want to have a specialist coronary surgeon, specialist TAVR surgeon, specialist this surgeon. Everybody has to have 250 volume or 150. We also have to think about access to healthcare. And I practiced in trained and lived in United Kingdom for a while. And I think the treatment was good. It wasn't bad. And it was a postcode or what we call a zip code lottery. I think access to healthcare is also important. Nowadays, so many insurances are restrictive. I saw 3 mitral valves last week, and I could not operate on either of them. They all wanted minimally invasive robotic mitral valve repair. They were nice P2 prolapse or A2 P2 prolapse. All the 3 patients' insurance was across the water in New Jersey, and the insurance company will not pay for it.
Well,
I
of
think
course, Nirav and I are both in-
my conversation at the end of they paid me out of pocket to come and see me, and I told them, you don't need a minimally invasive. Making her point is that you need a surgeon who's going to repair this valve. You will get a scar, you will take a little bit longer to recover, but you need a valve which is repaired with competence, which is going to last you a long time. And that's what you got to choose within the constraint of your insurance company, access to healthcare. So yes, we want to have 5 mitral valve surgeons in the country who are doing 1,000 operations a year, a la David Adams, but we cannot have that. We have to think about access to healthcare, insurance, and the demographics.
Yeah, it's interesting because Nirav and I are in the same market, and it's unbelievable. I mean, I'd say about 75% of the patients that I've seen over the last 3 years in New York have seen at least one other surgeon. My record was 7 surgeons, which is getting to be absurd. I assume here at the Texas Medical Center it's somewhat similar. Sam, you were going to comment on that?
Well, I was just going to kind of elaborate on what Nirav said in that we already have a living example in Europe and in other countries, non-U.S., of how centers can be very, very busy. It would be extremely rare to find a European center, and Mattia, you can maybe elaborate a little bit more, that does 200 hearts a year. That's something that happens in the United States, and that's where you get the 5 and 4 mitrals a year volume. And the last line of Joanna's paper there, the low volume surgeon in a high volume center actually does have better results. And so the question is, do we have too many hospitals and centers in the U.S. that are doing heart surgery? It's not the case in China. It's not the case in Europe.
Tom, yeah.
I just have a quick comment. You know, I know we talk about volume a lot, and it's intuitive to do so, but I think the more important metric is actually quality, and I think that's what Nirav was mentioning as well. I think it's quality and outcomes, and not just pure volume, because I think volume is only one side of it.
Well, I think that's an interesting discussion. Of course, there's competitive issues, that come into it. I mean, if it were up to my colleague and friend Dave Adams, every single mitral valve in New York would probably go to Mount Sinai. But of course, is that really what's best for patients in terms of access or also innovation? Because we do live in America where there's some freedom, and part of that freedom comes with innovation and competition and people doing new things. The next slide here, I just want to identify the different options for mitral repair. We've gone over these, but I'll quickly run through them again. There's, mini thoracotomy with or without the camera. Now, my only beef with the mini thoracotomy is there are a lot of people out there doing fairly large thoracotomies and calling it minimally invasive. I mean, to me, is that really advantageous over a sternotomy? Probably not. So, if you're going to have to make a, 10 to 15 centimeter skin incision and a large thoracotomy underneath that skin incision and put a big rig protractor in there, that's probably not any better than a sternotomy. And in fact, it may be more painful and more difficult than a sternotomy. May not be the best way to go. But a mini thoracotomy, port access with a camera, is a pretty good operation. The upper mini sternotomy is something not a lot of people actually know how to do, but I learned how to do it from a mentor of mine, Vince Scottiani, and it's very easy to go through the dome. It's actually easier than a lower mini sternotomy where you go through the groove. And then, of course, Dr. Chitwood added the robot to the mini thoracotomy. And it has some advantages in terms of repairing the mitral valve itself, but it's true that through that same incision, you can do it with port access instruments without the robotic system. So is that valuable? And then if there was, of course, my mentor, Doug Murphy, and guys like Lee Seawick, who perfected the totally endoscopic robotic, where you're not doing any rib spreading, you're just using ports. And then, of course, we've got this, this literal tsunami of transcatheter methods. I tell our fellows at Cornell that if they really want to know how to navigate the new world, maybe they shouldn't even go to the STS. Maybe they should go to TCT, because there is so much going on right now in that space, and whether or not that's going to pan out one way or another, depending upon the device, we don't know, but I think we have to take it very seriously. I also have doubts about whether surgeons are going to be the ones doing those procedures or not. There's no doubts that we're capable, but for every one of us, there's 100 of them being pumped out of interventional cardiology fellowships who are just dreaming of doing them every day. So we will see. And, of course, there's the MitraClip. I only mention the MitraClip even though I'm not a huge believer in it, because it is effective in some patients. It is actually one of our best friends, because they're often patients we don't want to operate on, and it's the only FDA-approved repair that's out there. And it's, certainly with the COAP trial, it's gained a lot of momentum lately. And then, of course, there's these apical all-pump neocords, which we can say, well, we don't put them on the heart-lung machine, but the data that I've looked at suggests that there is a failure rate coming up on a year with these devices that is a little bit concerning to me, vis-a-vis the lack of a ring. But then they say, well, we can put a ring on, but if that takes 8 to 10 hours to put an apical neocord with a large thoracotomy plus a percutaneous ring, is that going to be better than, say, a totally endoscopic robotic mitral? I don't have the answers. Did you have a comment?
I just have more of a comment about the previous issue on volume-outcome relationship, and I think it's without a question that if you do something more, you get better at it. So I think that goes without saying. Just from a perspective of working with the STS and QMTF with Vinay Badwar, looking at this again, I think at the current data, we look at it and it's the same story all over again. 25% of the surgeons do 5 or less mitral valve surgeries per year. 75 do less than 12, and only 25% of the surgeons in the United States do more than 12 mitral valve surgeries. And that's probably not really good enough if you do just 5 a year. The data scientist in me also laughs a little bit at that slide that you showed, no pun intended, but I think if you remove some of these data points, you would see that the curve looks very different and is driven by 2 surgeons essentially. So the question is, how is the outcomes, volume-outcome relationship best defined? And I think that's a very tricky issue. On the heels of what Tom Wen said, I would say that in all of these studies, what's really missing is quality and long-term quality of the repair, echo data. And what's not talked about enough is you can make a valve look like there's no MR when you leave the operating room, and it can stay like that. But how many patients of these where we accomplish that come back later with mitral stenosis? And I think that's one of the issues where we need to be careful not just to advocate to be aggressive and shrinking down the annulus, but also look at the long-term repairs and how we can best accomplish that to really be competitive with what undoubtedly is less invasive and minimum invasive, which are all the transcatheter technologies. Thank you.
Yeah, one thing I would definitely agree with is that with this tsunami of catheter-based techniques, the cardiologists are saying, well, wait a minute, surgeons, your results are not as good as you think they are. Okay, so even, I hate to keep bashing on Dave Adams, but even Dave Adams reports a 7% failure rate at 15 years or 20 years, I think. So there is a significant failure rate, and most of us think it may be higher, depending upon how you measure failure. So I do think that quality repairs, no matter how that's accomplished, needs to be a priority. If open surgery of any kind, or robotic surgery, or minimally invasive surgery, is going to stay in the game. versus catheter-based approaches. One thing I've noticed in New York, I don't know if it's true elsewhere, but is the rise of the general cardiologist, as opposed to the interventional cardiologist. So the general cardiologists are getting much more discerning in terms of results. So that, in New York, the MitraClip's not all that popular because they don't want to see all that recurrent MR that occurs, obviously, with the MitraClip, even though, we all know the debates and the discussions and the data. And so I think what's happening is that the general cardiologist is going to get more discerning when they look at results. They already judge our results pretty harshly, but they're going to start looking at catheter-based results as well. We need to be ahead of that and really report our results, look at our results, be honest about our results, and find ways to make them better. Dr. Kahn.
Honest about results is surely a good comment. When you go back to the slide in which we see how many surgeons are performing 5 to 10 mitral repairs per year, we also have to ask how many mitral valves are excluded, so that were shifted to replacement and not enrolled in the study. So this is probably another point, and to be true in reporting the data is important. And even because if we look at the guidelines, and we see that in class 2B we have that if in good ventricular function, so end diastolic diameter even less than 40 and ejection fraction higher than 60, we have that with a predictable higher rate of repair, more than 95%, which is surely a high repair in a scenario rate, in a scenario like this, in centers of excellence. So how we can define the center of excellence? Is it related to the volume, or is it related to the outcome? Is it related to both? So these are surely topics that are still open. And the only thing that I say is that it's important that we keep for the ontology and also for the patients for the next at least 10 to 20 years mitral repair in hands of surgeon, because we know that we can give better results than a transcatheter, because a gold standard will remain for a long time, minimal invasive or full sternotomy, but mitral valve repair.
Wonderful, wonderful comment. So we only have about 5.5 minutes left. I want to shift the discussion a little bit to complications of minimally invasive and robotic mitral valve surgery, particularly right chest surgery. So we'll just go through as many as we can. One I would point out would be postoperative bleeding. We know it occurs less in minimally invasive, but when it occurs, say, in a robotic endoscopic operation, it's a real problem. Difficult to get that clot out. Sam, do you have any comments on how to prevent that, how to treat it once it occurs?
Yes, so the majority of bleeding that happens in our robotic mitral cases is from the intercostal branches at the ports. And so the first way to prevent that is to don't let it happen, and insert the ports where you should be inserting, which is over the rib, not under the rib, and be very careful and dilate. I was amazed when I go proctor as to how many people don't actually use the dilator for the port placement and just kind of put the port with the dilator in it right away after a Kelly clamp. The second thing is, after you've taken all those precautions, is after you've given the protamine, really look very carefully, bring in a 30-degree upscope. Somebody was telling me they have a 60 or a 90-degree upscope.
It's Doug Murphy. He has a 70-degree scope.
Where did you get that from?
It's an ENT scope.
An ENT scope. Yeah.
Urology, yeah.
And so that's the only way to do
I
that
can't
is to
find it, but
yeah.
he-
I'd like
he
to
has
find
it.
one of those. And the other thing we'd like to find is that he's got a mediastinoscopy type suction electrocautery device. So if you remember your old, if you don't do mediastinoscopy anymore, I remember when I was a fellow, the best thing about that procedure is that you could suck and bovie at the same time with the same instrument. while you're looking, and that is just wonderful. And so if you have one of those, which Doug does, I don't know where he got it from, but that's
It's
another
also unobtainable.
unobtainable. That's another key element as you're looking around the ports when you're done. And
Yeah.
so once having done that, you basically try to prevent it from happening, and it's the worst thing. Once it's happened, I don't know, you can get somebody else to talk about what to do after it's happened. Just, I don't want to hog the microphone.
Yeah, I can say that. Well, basically, one thing I've learned the hard way is that when you're, in my case, my biggest incision is 12 millimeters. So I only have a very small port. So removing clot is a problem. And actually stopping bleeding from the chest wall can be difficult. It's hard to see it, basically. You know, you're sort of looking backwards. It's a rigid structure. I just find it much more problematic than, say, a take back after a sternotomy. I will sometimes leave them and try to have them clot off and sort of do more of a damage control strategy. Obviously, if they keep bleeding, they're unstable, they go right back to the operating room. But sometimes I'll delay, accept a retained hemothorax, and take them back the next day, because I've actually had the unfortunate circumstance of taking one back twice, where basically we couldn't stop the bleeding. It's easier to take them back in a delayed fashion. But
So when you take them back for bleeding,
yeah.
what's your incision?
Yeah, I will try the ports, and I have some thoracoscopic clamps that I'll put through to try and get the clot out. And if I can get a working space, I'll do it completely VATS, basically. If I'm struggling, I'll connect the working port and the camera port for a mini thoracotomy so that I can reach my hand in there and grab clot. But if I think that it's from the heart, I will just zip the sternum in a heartbeat.
Right.
I think that's an important thing, and I've done that a couple of times without hesitation.
Ralph, I'll add that the first thing that I do is look at the chest x-ray. If the mediastinum is wide and there's no hematoma coming in from the chest wall, that's a sternotomy, because that's coming from the heart. If, on the other hand, it's a slowly increasing kind of hematoma coming from the lateral, then I'll go back in with the robot. There's a beautiful device that we do not use enough robotically. It's called the suction irrigation device, and the gynecologists use it every day, and I use it every day on all my cases. I use it to test the mitral valve. I use it to suction irrigate and help me during the procedure, and I'll use it during a take-back. It is very effective in sucking up a lot of that clot, and then if that doesn't do it, then I'll do what he just said, connect the port for the camera and for the working port, and then you can put in bigger instruments to take it out.
Rob, any strategies for our last minute here? Any strategies on preventing unilateral pulmonary edema?
I think cooling the patient more.
Yeah. How cold do you go?
I go 30.
Yeah, so do I. Yeah.
I go to 30. I think that makes difference, and also not rewarm too fast as well. Previously, when I would do the water test, valve is perfect, then I would start rewarming. I don't do that. I rewarm. I mean, it might take a little longer, but I think these patients warm faster anyway, and then I would just wait.
Right.
She's got some experience.
Yeah, go ahead.
I think that you're talking about from the, when you're doing lung isolation, or?
Well, we don't know the mechanism, but it's a devastating complication. And basically, after you've come off bypass, you get frothy sputum coming from the ET tube. You cannot oxygenate. You often have to go back on bypass. Some patients have ended up on VV ECMO, and you get a chest x-ray, and the lung is completely whited out. Now, there are different grades of that, but that's the one we all fear.
We don't typically see that here, but I can imagine, are you using lung isolation for that?
Yeah, yep.
And it's on the side that it's on?
It's always on the right side.
Yes, exactly.
And no one really knows the cause. We've done about 15 different things to prevent it. Cooling, I think, is number one. I agree with Nirav. Avoiding pressurization of the lung. It tends to happen in patients with more pulmonary hypertension, so we're more cautious in those patients. We also use H1, H2 blockers and steroids, and just in case it's some sort of post-inflammatory thing. And when we put the lung back up at the end of the case, we put it up very slowly, thinking that it could be sort of a re-expansion pulmonary edema thing. When you put all those things together, we haven't seen it in a long time, but it is one of the most devastating complications of right chest mitral surgery. Yes, sir.
Something just to think about.
Yeah.
What can cause it also is if you narrow the pulmonary vein on that side.
Oh, yeah.
And through a real
That would do it.
small thoracotomy, and especially in a redo, that's not that hard. And I just would say be very careful in how you close that atriotomy, because that's a classic form, and that won't get better with anything you do.
That's
Yep.
right.
And you have to reoperate it, and it's one
anesthesiologist to look for. They can also look, and if there is high velocity flow from the right pulmonary veins, you've narrowed them, you've got to reopen the patient and reclose the atriotomy.
Right, that's classic for a lung transplant. That's the only time we ever see any of that stuff.
How would you fix it? So if, say, it's not a stitch that kind of went to the back wall of the
Patch it.
pulmonary vein. So have you done what kind of patch? What's the logistics there?
Never had to patch. I mean, usually it's the superior vein, and it's not that easy if you take one deep stitch to narrow it enough to cause that problem. Just take down your atriotomy, your left atriotomy.
Do it over
and then
again.
just restitch it very carefully. I've never had to patch it. I mean, that would be an interesting.
Yeah.
That's usually
The only time I've patched pulmonary veins is when I was sent a case from the electrophysiologist where they did RF ablation and they stenosed it, and I had to do longitudinal patch. No, this is not like that at all.
close the atriotomy.
Yeah, yeah.
and it's
Truly.
usually very simple. Well, it's not simple because the first response as a surgeon is to deny it, right? But once they convince you, or if you're suspicious enough,
Yeah.
I mean, really just taking it down, and it's sometimes just how you can get very close. It's much different than when you're closing it through a sternotomy.
Actually, we've had one case at Cornell in the past 3 years, and it was a sternotomy case.
But
Just saying.
They try to do it. I mean, you can get unilateral pulmonary.
Yeah.
from other things.
Yeah. Thank you very much. Great session. We'll stop it there.